when a lady during pregnancy presents with thrombocytopenia, what all things to be considered? What trimester of pregnancy? What is the severity? Pre-pregnancy results, associated symptoms, hemoglobin WBC abnormalities. This is something which will help us in understanding the etiologies underlying this thrombocytopenia. So this is in snapshot thrombocytopenias, their severity across various trimesters and their underlying main causes. If you see first trimester, majority ITP. Second trimester, severe thrombocytopenia, majority ITP. Moderate, mild thrombocytopenia, majority gestational thrombocytopenia. Third trimester, mild to moderate thrombocytopenia, most of them are gestational thrombocytopenia, whereas severe thrombocytopenia, where platelet count is less than 50,000, most of these are almost 3/4 are pregnancy-associated hypertensive disorders, and this is where a real timely intervention can save not just mother but also the child. Now coming to our cases, so this case, severe thrombocytopenia, first trimester, ITP, diagnosis of exclusion, no organomegaly, lymphadenopathy, hemoglobin WBC normal, her workup with LDH normal, autoimmune profile normal, does she need treatment, platelet count is 45,000, and the mode of delivery. Again, this is just the platelet threshold for various modes of delivery. Again, the mode of delivery has to be determined by the obstetric indications. Hematological severity of thrombocytopenia is not going to dictate the mode of delivery. Normal vaginal delivery 30 to 50,000, LSCS 50,000, spinal anesthesia 75, and patients, pregnant patients with the fetus having neonatal thrombocytopenia 50,000. So this is again, sorry for this busy slide, but this summarizes the management of ITP during pregnancy. So platelet count more than 50,000, any trimester, no treatment. 30 to 50,000, first and second trimester, no treatment. Third trimester, because we don't know the mode of delivery, so platelet, target platelet is 50,000 for LSCS, so steroids to keep the platelet 50,000. 10 to 30,000, without bleeding steroids, with bleeding IVIG, because that is the fastest acting drug. And again, severe or the severe thrombocytopenia 10 to 30, less than 10, with bleeding IVIG can be helpful. And remember, the goal, I see lot of obstetricians aiming very high platelet count right from the first trimester, which is wrong. You will load these pregnant females with lot of steroids and steroid associated morbidity. So target platelet count throughout pregnancy 30,000, 50,000 near term. So coming to case 2, she has mild stable thrombocytopenia. So after ruling out all other possibilities, it's a gestational thrombocytopenia. Just do watchful waiting every 2 weeks, near term platelet monitoring. Check the manual platelet count, because large platelets can be underestimated by the cell counters, and platelet count more than 70,000. The most of the various modes of deliveries are uneventful. So now case 3 is critical. She has already preeclampsia starting from 28 weeks. Now this is thrombocytopenia is worsening, her proteinuria is worsening, her hemoglobin is dropping, LDH high, haptoglobin undetectable, and urine shows 3+ albuminuria. So this is worsening preeclampsia, and this is the time you should promptly prepare the lady for termination of pregnancy. So she was taken up for LSCS, and 3 days post LSCS, her entire picture resolved. So just like an ECG for a cardiologist, endoscopies for gastroenterologist, and imaging like CT, MRI for neurologist, cell counter generated hemogram can be a very vital tool for not just hematological diseases evaluation, for any underlying medical condition. And cell counter generated hemogram, I just don't mean the numerical values, but also the histogram values. So again, hemogram and a well-read peripheral smear, the devil lies in the details, because peripheral smear with any abnormality other than platelets can be a very vital and timely tool to distinguish benign versus critical. Again, so many conditions, TTP, the classical pentad taught in the Harrison's medicine textbook is not seen in less than 10% cases. So most of these present with isolated thrombocytopenia, subtle mental changes which can be easily overlooked. But again, you see the critical thrombocytopenias like thrombotic microangiopathy, DIC, the patients are sick. There are schistocytes on the peripheral smear in these critical thrombocytopenias. In DIC, there is coagulopathy. And of course, why this is important? Because the treatment completely changes, and so is the mortality to both the mother and the child. So ITP, steroids, IVIG, TTP, timely plasma exchange, and DIC, of course, the treatment of the underlying cause. So remember, take home message, any patient with thrombocytopenia, reflexively from your pain, you should write LDH, very high LDH, peripheral smear for cystocytes, and early hematology consultation, organ functions with high LDH and cystocytes, neurological, renal, and coagulopathy should be checked, and early hematology. This is, again, sorry for this busy slide, but again, the entire evaluation diagnostic algorithm for patients with thrombocytopenia evolves around associated other abnormalities on the peripheral smear, on the hemogram, and the systemic examination of the patients. So you should know the good, bad, ugly of thrombocytopenia in patients with thrombocytopenia in pregnancy. Again, as I mentioned you earlier, thrombocytopenia with high LDH is a warning bell. Early hematology referral, prompt evaluation of these cases is important.